Hello, good evening.
Good evening. Yeah, good evening.
Okay, please, I'm Mabel. This is group 4, Keta. We are presenting on postpartum mental health. And
Okay, please, nothing is showing yet. I think you were about to select, but though your screen is showing, but it's not showing your slides.
my slide is not showing.
Yes, it's not showing.
Oh, okay.
So Miriam and Co, please kindly coordinate for me so that at exactly 15 minutes we change over.
Yes, sister.
Please, is it showing now?
Yes, please.
Yes,
Okay.
please.
This is our scenario. Mrs. Sarah, 31 years old, para 2, is now 3 weeks postpartum. Her husband brings her to see you because he is worried about her behavior. She has been crying frequently, expresses that she is a terrible mother, and has been unable to sleep even when the baby sleeps. She shows little interest in holding or feeding her baby, and her mother has taken over most of the infant care. During your conversation, she speaks slowly, avoids eye contact, and admits she sometimes thinks her family would have been better without her. She has a history of depression treated with medication 5 years ago. Her husband mentions that she has barely eaten in the past week and refuses visitors. So, we are starting with our definition of postpartum blues, postpartum depression, and then we'll continue with the assessment. So postpartum blue, also known as baby blues, refers to a mild fluctuation that occur after birth. They are considered a natural result out of hormonal changes and then physical demands that comes with having a newborn baby. With postpartum depression, is a mental condition that also occurs after birth, and it's characterized by mood changes, anxiety, and extreme fatigue. Postpartum psychosis is a severe form of postpartum depression. That is, if the depression is not resolved, it can proceed into postpartum psychosis. However, it can also happen abruptly on its own without any signs of depression. So this is our differentiation between the postpartum blues, postpartum depression, and then postpartum psychosis. This is the assessment criteria. So onset, with postpartum blues, it takes 3 to 5 days after birth. Postpartum depression takes 4 to 6 weeks. Postpartum psychosis is within 2 weeks, and onset is rapid. Duration, postpartum blues resolves 10 to 14 days, and depression, it persists more than 2 weeks. Psychosis, 2 to 12 weeks. However, it can last up to 6 to 12 months. With mood, postpartum blues, the woman becomes tearful and very emotional. And with the postpartum depression, she experiences sadness, helplessness, and with the psychosis, she has extreme mood swings. Maybe she will not like to talk to people, she will not like to see people, and all of that. And with the sleep pattern in postpartum blue is mild sleep disturbance. With depression is severe insomnia, and then with the psychosis, they may not even sleep at all. Then we move on to appetite. They have normal appetite with their postpartum blues, poor appetite in depression, and they may refuse to eat with their postpartum psychosis. Then bonding. With bonding, the woman still has attachment with the baby in the postpartum blues, poor bonding with depression, and may reject or even harm the baby when it comes to postpartum psychosis. Then with the thoughts, we have blues, there is no suicidal thoughts, and postpartum depression, possible suicidal thoughts. With the psychosis, she will have delusion, hallucination, hearing voices and seeing things that are not there. Then with the functioning, with the postpartum blue, able to function well, postpartum depression, poor functioning, and then with the psychosis, severely impaired. Treatment. In postpartum blues, you reassure the woman that everything will be well. It's just the demand of the baby that's making her to feel as such. She will get over it. And then with the depression, mostly is therapy and then medication. And with psychosis, it's extend to an emergency psychiatric care where the woman needs attention immediately. So,
Mr. Mabel, please let me continue.
okay.
Okay. So this Theodora. We have the Edinburgh postpartum depression scale, which is used to assess depression. So the abbreviation is EPDS. So most of them will use the abbreviation. EPDS is a reliable screening tool designed to assess mood, anxiety, coping, and suicidal thoughts in postnatal women who may be experiencing depression, in some cases, antenatal depression. There must be proper administration, accurate scoring, and prompt action, especially for self-harm thoughts. These are essential for effective maternal mental health care. It is a self-administered questionnaire consisting of 10 questions with 4 responses scoring from 0 to 3. However, question 1, 2, and 4 are reverse scores. The answers are based on how she felt over the past 7 days. So this is a questionnaire where you give the woman, then she'll answer the questions and you use to score her. Depending on the score, then you know what to do next. So purpose of EPDS. 1, screening for postpartum depression. 2, identify mothers at risk of suicide. 3, monitor progress of treatment. Then 4, guide referral decisions.
Sister Theodore, please, let's help you from here. Hello?
Okay, so interpretation of...
So we are looking
So
at the
interpretation...
interpretation of scores.
Okay.
Please, I'm Ibrahim Nastira. So we have a table here, and on the table we have the score, the interpretation, and the action you are supposed to take for each score you get. So for the first score is 0 to 9. So when the woman scores 0 to 9, meaning there's no depression likely. And the action you do is to do your routine care and reassurance. If the score is 10 to 12, then that means there's no depression. And your action is to repeat the Edinburgh postnatal depression scale and monitor her closely. If the score is greater than 13, then the interpretation here is probably there's a postnatal depression. So what you do is to refer her to the mental health unit for assessment. If there's any score where it's greater than the 10 questions you asked, then that means the woman has suicidal thoughts. And for that one, you have to, as a matter of urgency, refer her regardless of the total score she had. This is the next one.
So this is just the picture of how the questionnaire looks like. That one, we'll jump it.
How to administer the questionnaire to the clients? So first, you have to ensure privacy. For every procedure we perform to the client, we have to ensure that there is privacy. You explain the purpose of the questionnaire to the client so that she doesn't feel like you are bringing something out of the box to give to her. You explain the instructions to her. If she's illiterate, then you allow her to do the completion herself. But in cases where she's an illiterate and she would need for translations, you have to do that on her behalf. Sometimes, too, because of language barrier, you have to invite other people to come and help her. With that, you have to explain to her and make her understand that you are not sending her information outside for anybody. After the questionnaire has been filled, we check for its completeness. This is the next slide. We are looking at the significance of each question. With the question 1, you are going to look at her ability to laugh. If she's able to laugh, that means she has not lost pleasure. And with that one, the other name given to it is anhedonia. Then with question 2 is helping us to know if she hasn't lost interest in the thing she does. With question 3, Sister Mabel, the screen is gone.
Okay. And then, I'm sorry, is anybody having the slide again? My laptop is going off. So that I'll block it. Somebody should share it, please.
Please, if you're ready, you can start.
Good afternoon, please. We are Group 1. Presenting on low care assessment and postpartum hemorrhage prevention. So we start with the explanation of low care. Low care is the normal vaginal discharge after childbirth. It's made up of blood, mucus, and uterine tissues at the uterus hills and shrinks back to normal size. Please, someone should continue.
Okay.
Confidential. I'm
Ma,
speaking.
Hello.
Lokia
Sorry.
Teresa.
so continue. I'm
No,
Alima.
sorry, please. Let me chip this in. I think it's best when you read your question to us. So,
Okay.
like I said, everybody was given a scenario. So let's understand from that perspective, then we can follow what we're expected to do.
Okay, madam. Please, I'm Ahmed
All right.
Samira. So our
Okay.
scenario, Mrs. Grace Okonwo, a 35 years old preemie para, is now 4 days postpartum following a normal vaginal delivery. She calls you to her bedside because she noticed her lochia, which has changed from rubra to serosa yesterday, has suddenly become bright red again with unpleasant odor. She reports passing several clots the size of small eggs and experiencing low abdominal cramping. Her temperature is 37.8 degrees Celsius, and she mentions she has been very active, trying to do all the household chores since returning home yesterday. She is exclusively breastfeeding and her baby feeds well. So please, this is our scenario, and we will start by explaining Lucia, then build upon it. So please, someone will continue from here.
I'm confidential. Lokia is the normal vaginal discharge after childbirth. It's made up of blood, mucus, and uterine tissues. As the uterus heals and shrinks back to normal size. Please, next slide.
So I'm taking the lochia rubra, amalima. So lochia rubra is the first stage during the first to third day up to the fourth day. And then the color is bright red. It's made up of blood, decidual tissue, and clots. The amount of blood is heavy like a normal menstrual flow. And then we have the lochia serosa. The lochia serosa is the second stage, which starts from the 4th to 10th day, and then the color is pinkish or brownish, consisting of serum, leukocytes, and then old blood. This comes in moderate and then is decreasing. Someone will continue from where I just ended.
I'm Letitia. Lochia alba. The lochia alba is the third and last stage. It starts from day 10 to 6. Please shift there. And the color is whitish or yellow. Oh. Please go back to the And the color is whitish or yellow, consisting of leukocytes, mucus, and epithelial cells. This stage shows sign of healing.
I'm Mary. Abnormalities. Excessive lochia. Taking a pad in 1 to 2 hours or less, or continued heavy bright red flow after the first week. Causes: uterine atony, retained placental fragments, blood clotting disorders.
I'm taking the management. I'm Jennifer. So 1, we have to assess for vital signs and bleeding amounts. 2nd, you have to massage the uterus. The 3rd one, you have to give oxytocin and administer IV fluids. You take ultrasound if butane product is suspected. You transfuse blood if it's severe. And prolonged
I'm taking the prolonged lochia rubra. This is Linda. Hello. Causes of prolonged lochia rubra. We have subinvolution, infection. Then the management, you have to reassure the client, you assess vital sign, you massage uterus, then rest administration of urotonic, the antibiotics administration. Foul-smelling lochia causes, we have an endometritis. It is the inflammation of the uterine lining caused by infection, commonly presenting with fever, lower abdominal pain, and abdominal vaginal bleeding or discharge. Please, the next slide. Someone should continue.
So I'm Patricia also. I'm taking the management. Reassure clients. Admit clients if moderate to severe. Administer prescribed broad-spectrum antibiotics. Administer analgesics and antipyretics. Maintain strict perineal hygiene. And also remove retained products if present. Someone should take it up from there.
I'm Elizabeth Amponsa. We are moving on to the scenario. Sister, please, can you move to that, please? Thorough assessment of Mrs. Okolokia. A, history taking. So you take the history of the onset and duration of the bleeding. When the bleeding changes to amount per the pad, and you ask the person there, you ask Miss Okonko how many times she has changed the pad, the number of pads she has changed, and presence of clots. How was it? The size of it and the frequency of the clots. You ask Mrs. Oko the odor, whether it was having a foul smell, which suggests infection. We have associated symptoms. That is the abdominal pain, fever, dizziness, active level. She has been very active in the scenario given. Breastfeeding pattern. She's doing exclusive breastfeeding. Please, someone should also continue.
Okay, I'm taking here. Physical examination. You take the vital signs, and the vital signs was 37.8 degrees Celsius. Low grade fever. Founder height assessment. That's position, firmness, and then tenderness. Check for uterine sub-involution. Inspect perineum. Assess lochia for color. That is, if it is bright red, amount, odor, unpleasant odor, clot, size of small eggs. There's someone should also take from this place. Someone should also take from this place.
I'm Georgia, and we are moving on to differences between normal and abnormal lochia. Features. We have the features, we have the normal and abnormal. Under the first feature, we have color progression, and under the normal lochia, we have from rubra to serosa and to alba. But with the abnormal lochia, reversion to bright red after serosa. We move to the second feature, that is odor. Under odor, with the normal lochia, we have flesh-like, and the abnormal lochia, it is foul smelling. Under the third feature, that is clots, we have the normal lochia to be small, that is less than 3 centimeters. Under the abnormal labor, we have large, frequent clots. The fourth feature is amounts. With the normal lochia, it is gradually decreasing, but with the abnormal lochia, there is sudden heavy flow. The fifth feature is the fever. Under normal lochia, there is no fever, but abnormal lochia, we have greater or equal to 38.0 degrees Celsius. That is for the temperature. The last feature is pain. Under the normal lochia, there is mild cramping. Under the abnormal lochia, there is persistent lower abdominal pain. Someone should take over.
So please, I'm taking over the second one. I'm Sarah Jobia Danso. A chart showing the expected progression of lochia from day 1 to week 6 postpartum. We have the time, the type. Day 1 to day 3, there is rubra. It's rubra and it's bright red, moderate flow, and small clots. Then from day 4 to day 10, it's serosa, and the characteristics is pink, brown, and lighter flow. And from day 10 to day 6, from day 10 to 6 weeks, it's lochia alba, and it is yellow, white, and scanty. So please, someone should take over from there.
Please, I'm continuing. I'm Esther Opoku. Possible causes of her symptoms and differential diagnosis. Into bracket prioritize. We have retained placenta tissue or sub-evolution. It is sudden heavy red bleeding and clot. Uterine infection. That's endometritis. It is foul odor, fever, and abdominal pain. Then secondary postpartum hemorrhage, excessive bleeding, hemodynamic changes, then excessive physical activities, which aggravate the normal evolution. Then 4, recommended investigation and management plan. So these are the investigation we do.
Please let me continue with the investigations.
Please, you say?
Let me continue with the investigations.
Oh, okay.
So, recommended investigations and management plans. We have full blood count, HB, WBC. We have high vaginal swab, ultrasound scan, and then into bracket check retained products. C-reactive protein. Next, management.
Let me
First,
continue with the management.
okay.
Okay, please, I'm Clara Boaji. So the management, you monitor the vital signs. That's the temperature, the pulse, respiration, and the blood pressure. Then the uterine massage, you massage is 15 minutes, 30 minutes, and hourly. Then you administer uterotonics. That's the oxytocin or misoprostol. Then you start broad spectrum antibiotics. Then you encourage rest. Next.
Okay, please let me come out with the patient.
Let me end it.
You said what?
Okay, let me finish it.
Okay.
Patient education. Explain normal local stages. That's rubra to serosa to alba and expected duration. Point 2. Describe abnormal signs like sudden red bleeding, large clots, foul smell, fever, or excessive pain. Point 3. Advise activity moderation in the first 2 weeks. That's rest, avoid heavy chores. Point 4. Instruct to seek urgent care for heavy bleeding, large clot, fever greater than 38.0 degrees Celsius, or foul smell and abdominal pain. Please, next slide. 6. The final
can I
part.
also take?
Okay.
Okay, my name is Patient. I'm taking. Jemima, are you taking it or I should continue?
Let me take it then. Let me continue to the end. Okay, relationship between breastfeeding, uterine involution, and lochia. So, summing up all what we did, they are saying that breastfeeding stimulates oxytocin release, which promotes uterine contractions and accelerates involution. And then again, efficient involution reduces lochia volume and speeds transition from rubra to serosa and then alba. Then finally, persistent.
Please, it's time.
Please, I'm almost done. Persistent heavy load. Thank you.
Please, the next group can start. Thank you.
I was waiting for
Good evening.
Good evening.
Patience Jiago, Group 9. We are presenting on newborn care, education, and maternal infant boarding. Lillian, next slide. So our scenario is Mr. and Mrs. Daniel Owusu are first-time parents of a baby girl born 24 hours ago. They are both professionals, highly educated, but appear completely overwhelmed by basic infant care. Mrs. Owusu, 36 years old, is afraid to hold the baby, saying she is too fragile and might break. She has not attempted skin-to-skin contact. Mr. Owusu asks numerous questions about every small thing. Every small thing, has been researching everything online and is anxious about conflicting information. The baby has physiological jaundice, slight weight loss, and the cord stamp is still fresh. The couple is concerned about the baby's irregular breathing pattern, frequent sneezing, and a small white spot on her nose. They have already purchased numerous essential items, including a baby walker, honey for hiccups, and gripe water based on online regulations. So we are moving on to cord care. So with cord care, you need to keep the cord clean and dry. So you sponge bath the baby only until the stamp falls off. You fold the diaper below stamp to prevent contamination. You allow the cord to dry naturally. So you don't apply any alcohol or antiseptic. It is worth noting that alcohol destroys healthy bacteria that helps the stamp detach naturally. WHO has recommended that the cord should be kept dry. So now it is recommended to practice dry cord care. The stamp falls naturally within 1 to 3 weeks. So you need to watch out for redness, swelling, foul odor, or bleeding of the cord.
Please let me continue.
Okay.
The thermal regulation. So we are continuing from thermoregulation. We maintain moon temperature, that is 20 to 22 degrees Celsius. We dress baby in one more layer than adults. Then we use hat for the first 24 hours. Then only if cold. So when the weather is cold, when you dress the baby, you have to put on hat for the baby. But if the weather is normal, you leave it like that. You check temperature, auxiliary, 36.5 degrees Celsius to 37.5 degrees Celsius, normal. Signs of cold stress, cold extremities, lethargy, poor feeding, signs of overheating, sweating, flushed skins, rapid breathing. Please, someone should continue.
Please, I'll continue from here. I'm Regina Aisia. Sister, please clear it from the...
Hello, please. My name is Mavis Akese. I didn't mention my name. Thank you.
Okay. Skincare. Point 1, Venus caseosa, natural moisturizer, does not tape off. Point 2,
sponge bath until cord falls off, and then 2 to 3 baths per week. And point 3, use mild fragrance-free baby soap. Point 4, moisturize dry skin with plain petroleum jelly. Then point 4, diaper rash barrier cream, that is zinc oxidized. Frequent changes of the diaper. And then point 4, avoid powders, that is inhalation risk and talcum powder. Please, another person should also continue.
Okay, I'm Priscilla. I'm continuing from the danger signs. We have a danger signs: convulsion, fit, caution, lethargy, weakness, fast breathing, that is greater than 60 beats per minute, or chest indrawing, yellow palms, sores, yellow palms and sores, that's jaundice. And then we have fever greater than 38 degrees Celsius, that's the temperature, or hypothermia less than 35.5 degrees Celsius. And then refusal to feed, stroke poor feeding. Okay, the next slide.
So I'm taking notes from here. My name is Comfort in Champo. We have the normal newborn characteristics. The first one being physiological change, jaundice. This is expected as jaundice appears in 60% of term newborns. It's caused by immature liver function and increased red blood cell breakdown. It appears day 2 to 3, peaks day 4 to 5, and resolves by the 10th to 14th day. So management is by frequent breastfeeding at least 8 to 12 times per day, and monitor color. That is, phototherapy is only recommended if the bilirubin levels exceed treatment threshold. Warning: jaundice in the first 24 hours or lasting less than 2 weeks lasting more than 2 weeks needs investigation. We know that when the baby is born, the red blood cells breaks down because in utero it is small. So as the red blood cells are breaking down, it will lead to physiological changes. Then when we talk about the breathing patterns, the normal periodic breathing pattern is irregular rate with 10 seconds pause. Normal rate is ranging from 30 cycles per minute to 60 breaths per minute. Abnormal breathing pattern is greater than or lesser than 20 seconds with grunting, nasal flaring, and chest retractions. Newborns are obligated nose breathers. Should I continue or not? Someone will take it. Then the point 3, frequent sneezing. This is normal physiological response. This happens to clear nasal passages of amniotic fluid debris and a response to new environmental particles. It is not a sign of cold or illness unless with fever or poor feeding. A white spot on the nose, that is milia. This is a benign and self-limiting tiny cyst from blocked oil glands. It appears on nose, cheeks, and chin and disappears spontaneously within weeks. It is important not to squeeze or treat. So it doesn't need treatment or we shouldn't break them. And then the fifth. Okay.
Sister, please, I'm Veronica Ayoko, a member of Group 9. Waste loss. This is an waste loss. This
We can't hear you, Sister Veronica.
Please, I'm Ernestina. I'm continuing. Weight loss. This is an expected physiological adjustment of losing about 7 to 10% birth weight, which is regained by day 10 to 14 with adequate feeding.
Adjustments of losing about 7 to 10% of day 10 to 14 with regained by 2 weeks. It is with feeding. Hello, please move on.
So skin to skin, mother should sit in a semi-reclined position, that is 45 degrees. Ensure privacy and warm room temperature. Remove baby's clothing except the diaper. Position baby prone on mother's bare chest between breasts. Turn baby's head on one side for clear airway. Drape core sheet over baby's back, that is excluding the head. Ensure baby's nose and mouth are visible at all times. This will ensure proper breathing. Minimum of 60 minutes uninterrupted for first session. Continue for as long as comfortable, especially during the first 3 months. Monitor for airway obstruction. Avoid falling asleep with baby on chest unless in safe setting with supervision. Evidence-based benefits. Mr. Lillian, please remove that thing. 2025 Cochrane Review. Immediate skin-to-skin contact increases exclusive breastfeeding at 1 month. The evidence is now so strong that trials without skin-to-skin as standard care are considered unethical. Now, benefits of skin-to-skin to the baby. Optimal thermoregulation, that is maternal breast temperature rises and keeps the baby warm and stabilizes blood glucose levels. It improves oxygen saturation, better brain development and self-regulation, and colonization of healthy microbiome. For the mother, it increases oxytocin, it reduces postpartum bleeding, and lowers stress and anxiety. So education on the foodstuffs and items that were bought by the couple. Please, Sister Lillian, go up. Our time is fast running. So for the honey for the hiccups, honey is unsafe before 1 year because it contains Clostridium botulinum spores, which causes infant botulism. Hiccups are normal, harmless, and self-limiting, so it will go by itself. And with the gripe water, most gripe waters contain unregulated ingredients, sugar and alcohol. Some brands may contain sodium bicarbonate, which may alter blood pH and risk of choking during administration. Baby walker. This is not recommended because it increases injuries. That is falling on stairs, drowning in pools, and delay walking by strengthening the wrong muscles. Note, in Canada, baby walkers have been banned since 2004. Please move. So feeding, babies should be breastfed for at least 8 to 12 times in 24 hours. With adequate amount of breast milk, stools should change from meconium, that is greenish, to yellow. By day 5, babies should have about 6 to 8 wet diapers. Behavior, babies should have a strong cry, able to move arms and legs equally. Color, Check lips, tongue, nail beds. Pink skin color means good oxygenation. Blue color means or gray means low oxygen
Thank
test.
you. Your time is up. Next group.
Thank you.
Good
Hello.
evening. We have 5 members and we are presenting on breastfeeding and lactation. Introduction. In the case of Miss Jennifer, 18 years old primate, struggling in pain and emotional distress, and a sleepy jaundiced newborn, comprehensive breastfeeding assessments and tailored supports are critical. Midwives play a role in evaluating feeding effectiveness, guiding positioning and attachment, managing maternal breast complications and supporting the mother emotionally while countering family pressure. Understanding the physiology of lactation enables the midwife to provide evidence-based intervention that restores confidence and promotes successfully exclusive breastfeeding. Our objectives. Please, someone should continue.
Please, I'm Sarah Mesa. Objectives of presentation. Conduct a comprehensive breastfeeding assessment. Formulate a immediate management plan for common breastfeeding problems. Demonstrate appropriate breastfeeding position. Develop an individualized feeding plan for special situations. Provide holistic counseling and psychosocial support. Explain the physiology of lactation. Comprehensive breastfeeding assessment. A comprehensive breastfeeding assessment is a systematic evaluation of the mother-infant dietary, identify strengths, challenges, and factors affecting effective breastfeeding. It includes assessment of the mother, the infant, and the feeding process, especially observation of a complete breastfeed. This assessment enables early detection of feeding difficulties, support individualized care, and ensure adequate milk transfer to promote newborn growth and maternal comfort. Please, can someone take over? Okay, maternal assessment. Maternal comfort
Please,
and
let me take
positioning.
over.
Okay.
Maternal assessment, maternal comfort and positioning. Please, I'm Ruth Apenegomesi. Evaluate whether the mother is relaxed, supported, and comfortable. 2. Observe whether she needs help with back support, pillows, or positioning aids. 3. Assess her confidence level, anxiety, or pain during breastfeeding. Maternal medical, emotional, and social factors. Check for postpartum pain, anemia, fatigue, or medications that may affect lactation. 2. Assess emotional states, fear, frustration, or feelings of inadequacy can inhibit oxytocin release. Identify family pressures, cultural beliefs, or lack of support that may impact breastfeeding success. Please, someone else should continue.
Please, I'm Beatrice Abugui, and I'm continuing with the feeding cues. You identify early cues such as rooting, hand-to-mouth movement, lip smacking, light fusing. Late cues such as crying indicate feeding delay and can impair effective latch. Infant weight and hydration status. Assess weight loss. The normal is up to 7%, which is greater than or equal to 10%. Requires intervention. That is greater than or equal to 10%, requires intervention. Then you check the urine output, stool color, and frequency to assess hydration and milk intake. Then you also check for jaundice. Excessive sleepiness and dehydration may indicate poor feeding. Thank you. Please, next person should continue.
Please, I'm
Observation.
Hello.
Teacher. Please,
Please, I'm on the observation of the full breastfeeding. I'm Josephine, a Georgia Poma. This is the core of breastfeeding assessment. The midwife should observe the entire feeding process from initiation to completion. Position. Assess whether the baby is held close, chin touching the breast. Head and body are aligned. That is the ear, shoulder, hip in one straight line. Baby's nose is opposite the nipple. Baby's body faces the mother. That is the tummy to tummy. Poor position is the leading cause of cracked nipples and ineffective feeding. Please, someone should continue.
Latch. That is the attachment. 1. Evaluate. Baby takes a large mouthful of breast, not just the nipple. 2. Mouth is wide open, lips flange outward like a fish. 3. More of the areola is visible above the baby's top lip than below the bottom. Tongue is visible capping the breast. No clicking sound or dimpling of cheeks. That if you see dimples, it means baby is not suckling well. Poor latch often leads to nipple pain, trauma, and poor infant milk transfer. You can see the pictures below. So that's a good latching.
Okay.
Please continue.
Okay, please go back so that I can continue. Please go back to the previous slide.
Please, that's it. You continue from here. We've seen
Yeah,
the
you
picture.
continue from here. Yes. Okay. My name is Fosia Benedicta. So I'm continuing from assessment of mother and infant interaction. As midwives, we are supposed to look out for emotional bonding, eye contact, and responsiveness. We have to continuously remind the mothers. In our scenario, the mother is an 18-year-old girl. So we presume she has little or no experience at all. So we have to remind her that the baby is part of her so that she can bond with her naturally. Eye contact and responsiveness are also very important. The mother should be ready to handle the baby, and we have to make sure that the baby is also ready to breastfeed. The next point is mother's confidence and ability to manage the baby's cues. We have to make sure that the mother is confident enough to handle the baby. Most of the times, they are very scared to handle babies because they haven't had that experience before. So as midwives, we are supposed to encourage them to be able to handle their babies and also to look out for signs that they would have to report that needs to be taken care of. Then the next point is the need for reassurance, physiological support, or education. When we educate mothers on the importance of breastfeeding to themselves, to the mothers, and also to the babies, such as breastfeeding being a form of family planning
Please,
method.
sorry for interruption. Is the screen showing?
Yes, please.
Yes, it's
Oh,
showing.
okay.
Yes.
I can't see it, so that's why.
Yes, it's showing. Okay, so please let me go on. I was explaining the last point, which is the need for reassurance, psychological support, or education. So I was saying we should educate mothers on the importance of breastfeeding to the mother herself and also to the baby. So if mothers understand that breastfeeding is a source of family planning and also it will aid in baby's digestive system and also help clear jaundice, I think all this coming together will enable the mothers to be able to put their babies to breast. In this scenario, it will enable our mother since she is a first timer and has less experience. Thank you. Please, the next person should continue.
Management of the cracked nipple. Please, my name is Mary Chi. 1. Correct latch and positioning immediately. After positioning the baby, ensures that the baby's mouth is wide open, covering most of the areola, and also ensure that baby latches properly to reduce trauma. Point 2. Apply express breast milk and allow to air dry. Apply a few drops of breast milk and let it air dry. That will promote healing and also protect the nipple. Point 3. Use purified lanolin or nipple cream if needed. Apply lanolin cream after feeding. It will soothe and protect cracked nipple. And point 4. Avoid harsh soaps or aggressive. Clean nipples with only clean water. That will prevent further irritation. And also point 5. Monitor for infection. Watch for signs of redness, swelling or pus, and also check for pain or discharge. Please, someone should continue.
Please, Dr. Cecilia Show, I'm managing engorgement. So in case of engorgement where the breast becomes hard, edematous and warm, you you feed frequently every 2 to 3 hours to release the breast of its engorgement. Then you do warm compress before you feed and then cold compress after feeding to ensure comfort to the breast. Then gentle massage and reverse pressure softening to release the breast of its pain and engorgement. Then if the baby was unable to latch properly, in case of our mother, you express some of the breast and do cup and spoon for the baby. Then you position well, you educate the mother on how to position the baby well while breastfeeding to relieve the breast of its pressure and pain. Please, next person.
Sisters, please, I'm Evelyn Owusu. I'm taking the managing infants weight loss. The
Please,
first point is, hello, sisters.
We
Hello,
can hear
please.
you.
Okay,
We are
so I'm
listening.
Evelyn Owusu. I'm taking the managing infant weight loss. The first point is you feed at least 8 to 12 times a day. Then you wake the baby every 2 to 3 hours if sleepy. Then the third point is you use breast compressions to increase milk flow. Then the fourth point is monitor weight and dirty diapers daily. Then the last point is you supplement with expressed milk if clinically indicated. Please, somebody should continue.
Breastfeeding positions. Please, I'm Linda. 1. Cause CODeL hold. Excellent head support for small or sleepy infants. 2. Football or rugby hold. Ideal for engorged breast, section or twins. The next point is side lining position. Reduce nipple pressure and allow mother to rest. And then last one, emphasis, correct alignment, ear, shoulder, hip in a straight line, chin touching breast, and then tummy to tummy. Thank you. The next person.
Please, I'm Rashida Hassan. I'll take the feeding plan for jaundice and sleepy baby. 1. Schedule feeding every 2 to 3 hours. 2. Skin-to-skin contact to improve alertness. 3. Hand expression to supplement feeding if baby too sleepy. 4. Monitor hydration, weight, and bilirubin levels. 5. Avoid formula Avoid formula unless medically indicated. And then planning return to school. Introduce expressing and storing milk at 4 to 6 weeks postpartum. 2. Create a pumping schedule during school hours. 3. Teach proper milk storage and hygiene. And then 4. Encourage exclusive breastfeeding at home and save supplementation at school if needed. Thank you. Please, somebody should continue, please.
Please, I'm Teresa. I'll continue with the counseling and emotional support. So you validate the mother's feelings and fears, and then you reassure that early breastfeeding challenges are common. You also address family pressure with education on exclusive breastfeeding, and then you teach coping strategies for stress, fatigue, and then returning to school. Then you promote maternal confidence and bonding with infants.
Please, your
Thank you.
time is up. Thank you.
Thank you too.
And please, in the chat, I time them 15 minutes. I don't give a group 20 and then I give 1:15. So when it's time, I will say it. I'm not favoring anybody. Thank you very much.
Okay, so with the physiology of lactation. Okay,
Please, can we start?
Yes, please, start.
Please, we are group 2 and we are presenting on perineal care and wound healing. And we will start with our scenario. Mrs. Fatima Hassan, a 24-year-old primipara, had a medial lateral episiotomy during her delivery 5 days ago. She presents to the postnatal clinic unable to sit comfortably, walking with difficulty, and reports she has avoided passing stool for 3 days due to fear of pain. On examination, you observe the episiotomy site is edematous, with areas of wound dehiscence approximately 2 centimeters, purulent discharge, and surrounding erythema extending 3 centimeters from the wound edges. She has been using traditional herbal preparations applied directly to the wound as advised by her mother-in-law. So we will discuss and document a complete perineal assessment using the reader skill, explaining each component. What are the risk factors that contributed to wound infection and breakdown in this case? Develop a comprehensive wound care management plan, including cleaning technique, positioning, and pharmacological treatment. How will you address the constipation issue with appropriate interventions? And explain the relationship between bowel care and perineal healing. Create a culturally sensitive education plan that addresses the use of traditional remedies while promoting evidence-based perineal care. Design a follow-up schedule and criteria for referral to a specialist if needed. So now we start our presentation, and hopefully by the end we'll be able to address the scenario. Thank you. Auntie Susan, you can start.
Okay.
Madam
Please,
Rashida, please, you are making noise.
Please, I'm Susan Amponsa. I am continuing with the introduction. Refers to the specific hygiene and maintenance of the perineum. While it is a standard part of a daily hygiene for everyone, it becomes critical medical focus after childbirth. This is due to the fact that the perineal muscles and tissue have undergone significant stretching, bruising, and tearing during childbirth. The WHO provide a comprehensive guidelines for postnatal care, which emphasize that the first 6 weeks postpartum are critical for the long-term health of both mother and baby. Perineal care and wound healing is one of the most critical steps for the mother during postpartum. So perineal care is the cleaning and care of the perineum, especially after childbirth, to promote healing and prevent infection. Sister Nelly will continue.
Okay, so I'm Ada Ineli Emilia. Perineal care focuses on three main parts, which is hygiene, pain management, prevention of complications.
Sisters, please, I'm taking up. I'm Ophelia Matilda. Hygiene, also known as the clean and dry routine. The primary goal is to keep the perineum clean and dry to prevent infection and promote tissue healing. Then daily washing. The perineum should be washed at least once a day using plain lukewarm water. A perineum bottle can be used if client has it. On the other hand, vulvar toileting should be done for bedridden or cesarean section patients. And also, you avoid irritants. The use of soaps, wipes, and antiseptic creams should be avoided unless specifically prescribed, as this can irritate sensitive healing tissues. This is especially important when the client has an episiotomy or tear that has been sutured. Also, drying. After washing, gently pat the area dry with a clean towel or allow it to air dry. Do not rub. Always wipe if needed from front to back. This helps prevent bacteria from the anal area from reaching the vaginal opening or stitches, if any. Please, next slide. Sanitary pads or napkins. Always change sanitary pads every 4 to 6 hours or after using the bathroom. This should be done even if the pad is not soaked. Doing this helps prevent moisture buildup, which can slow down healing. And also air it out. If possible, you spend 10 to 15 minutes a day lying, like in a same position, on a clean towel without underwear, or let the area air dry completely. 2. Pain management. With the pain management, you apply ice packs, that's frozen maternity pads, wrapped in the soft cloth on the perineum for 10 to 20 minutes at a time during the first 24 hours. This helps to relieve pain and reduce inflammation of the perineum. Then we have tease bath. After 24 hours, a shallow soak in warm water, no salt or bubbles, for about 10 minutes can increase blood flow and soothe the area. Please, is someone ready to take up? Okay, then we have the pain relief. For routine perineal pain, paracetamol is generally... Oh, okay. Because of the time.
Veronica, mute your mic. What's that?
Pain relief. For routine perineal pain, paracetamol is generally recommended. For more severe pain, NSAIDs like buprenorphine may be provided. There are no contraindications. 3. Prevention of complications.
Prevention of complications. I'm Victoria.
The bladder should be emptied frequently after this helps prevent BPH, bladder incontinence, and unnecessary discomfort and pain happen. For clients who have difficulty emptying their bladder, a catheter should...
Sister Victoria, please, we can't hear you. Can't you tap your mic?
Please let me take from her. Prevention of complications. Bladder health. The bladder should be emptied frequently after delivery. This helps prevent postpartum hemorrhage, bladder incontinence, and unnecessary discomfort and pain after delivery. For clients who have difficulty emptying their bladder, a catheter should be passed to empty or to drain the urine.
Yeah, sure. So with your idea.
Bowel health. Encourage the client to eat foods high in fiber and drink lots of fluids to help soften the stool to be able to pass. Avoid straining when using the toilets. This can be prevented by using a stool softener, using a probe to probe your leg up while using the toilet to avoid easy bowel movements. If needed, we prescribe stool softeners to help with bowel movements. Encourage splinting, that's holding a clean pad against the perineum while defecating to provide physical support. Next person should continue. Okay, let me just.
I'm continuing.
Okay.
This is Annette Ejewaochi with the pelvic floor health. After the initial pain subsides, the pelvic floor muscles training, that is the CODeL exercise, is encouraged. This helps increase blood flow to the perineum to speed up healing and strengthen the muscles to prevent long-term issues like urinary incontinence. Please, let's continue. With the perineal wound healing.
Perineal wound healing. I'm Grace. Perineal wound healing is a biological process that follows a predictable timeline. A balance of clinical monitoring, pain relief, and hygiene is needed to ensure that tissues recover without long-term complications. 1. The healing timeline. Most perineal wounds follow this general recovery path. Inflammatory phase, day 1 to 3. This is the peak of swelling, bruising, and stinging. This occurs as a result of the influx of the white blood cells to the area by the body to help prevent infection. Proliferation phase, week 1 to 2. The edges of the wound start to knit together. Stitches may start to feel tight or tickly as the swelling goes down and the skin pulls
Madam
together.
Sandra, you are
Hey, don't
disturbing.
start.
Please, next slide. Next slide. Please, next person should continue.
Okay, I'm Gifty, the remodeling phase, with 3 to 6. The wound is closed and then the body begins to strengthen the new tissues. Stitches usually dissolve or fall out during this time, 6 months plus. While the wound is healed by 6 weeks, the deep tissue continue to gain strength and elasticity for months. Then the point 2, clinical monitoring and assessment. WHO recommends that the postpartum woman should be admitted for at least 24 hours after delivery. If she sustained a tear or episiotomy which has been sutured, this is essential for monitoring immediate complications like hematoma or infections.
Sister, please let me continue. Okay, please, my name is Gifty Bimpon. I'll be taking the perineal wound assessment. So with the perineal wound assessment, we use what we call the reader scale. And for the reader scale, you check first for redness, is to assess for vasodilation due to inflammatory response. A pink coloration will show healing, whereas a deep purple or bright red is a danger sign which needs to be assessed or referred. Secondly, we also check for edema or swelling. The swelling will be there for the first 48 hours, but after 72 hours, it's supposed to recede. So if a client comes and there's still swelling, you need to refer. And then thirdly, you use ecchymosis or bruising. You check for the bruising or discoloration. It will gradually turn yellow or green and then fade after the wound has healed. Please, next slide. Then you check for discharge. It is a clear or blood tinged discharge is normal during the first few days. It will gradually change to yellow, green, or any swelling pass will indicate an infection. Then you also check for approximation, which is you assess how well the edges of the wound stay close. If they are not staying close or kissing together, there is dehiscence, which means the wound is not healing properly. These routine checks will be done at every postnatal visit from the first 24 hours till after 6 weeks to make sure that the wound heals properly. Please, someone should continue.
Please, my name is Beauty. Today I'm taking the pain management and antibiotic treatment. Local cooling. Apply ice pack to relieve the pain and reduce swelling. We have oral analgesics. Paracetamol and NSAIDs like brufen are recommended for managing perineal pain and are also considered safe for breastfeeding mothers. Prophylactic antibiotics. We give broad-spectrum antibiotics as prescribed. Broad-spectrum antibiotics are prescribed as prophylactic treatment and also treat purulent infections. Next slide, please. Other forms of management are proper perineal care, pelvic floor muscle training. Next person should continue.
Okay,
Hello, please,
I'm going to
Asabia
factors that
Lerote.
promote healing. We have a setback. This is recommended after the first 48 hours of postpartum. There is increased vasodilation around the perineal area, which promotes healing. And we have protein and vitamin C. And encourage the client to consume more lean protein, citrus and leafy greens if they can afford. These enable the body to produce more collagens, which is essential for tissue repair. Then we have hydration. We encourage the client to drink more fluid to help the skin stay hydrated and also speed up the healing process. Then we have the next one. Okay. I'm Evelyn. Air out. Encourage clients to wear breathable cotton pants. Also, she can be lie down on a clean towel for about 15 minutes a day to allow the perineum to dry out the wound and tauten the skin. Risk factors for infection and breakdown. 1. Traditional herbal preparation. 2. Parity. That's the parity.
Thank you. Your time is up.
Hey.
Yes, please. Next group.
Sisters, please, good evening. We are Group 6 from Takrade. My name is Ndalide Danfosu.
Please, good evening. We are Group 3 from Asanko, and we are presenting on infected episiotomy. So we are reading a scenario before. Case study presentation on Mrs. Fatima Hassan's postnatal complication management. 24-year-old Pueriperium had mediolateral episiotomy 5 days postpartum with pain, difficulties sitting and walking, avoided stool for 3 days, wound edema, 2 centimeters dehiscence, purulent discharge, and she applied traditional herbal preparations. Please, someone should continue with the perennial assessment.
So please, I'm Elizabeth Ahensan. I'll continue from this point. So with the perennial assessment, as our previous group presented, we are going to use the reader skill. So the R stands for redness, which is erythema, extending 3 centimeters. That one is severe. Edema, that one you also assess for edema, marked swelling present. We also have another E, which is ecchymosis. You also assess for bruising. The D is for discharge, purulent or serous discharge present. The A is approximation. 2 centimeter wound separation indicates severe infection and wound breakdown. Please, the next slide. So risk factors for infection and breakdown. This point is related to the patient, so patient related. Pueriperium, that is tight perineal tissues, poor bowel movement, straining because of the movement of the bowel is poor. The patient will try to strain herself when defecating. Fear of pain, stool retention, because the client feels pain. She tried to retain the stool. She will not go. She will not pass the stool, so she tried to retain the stool. Possible poor hygiene. It's also another cause why the wound is infected. Clinical features. This is as a result of maybe our negligence or us not doing the suturing well. 1 is mediolateral episiotomy. 2, possible improper suturing technique. And the 3 is possible contamination during delivery. This is as a result of clinical factors. Please, the next slide. Risk factors for infection and breakdown. So we also have the cultural practices. Because the clients are...
Hello.
Okay. You want to continue, right? Okay.
I'm Esther Badu. So as my sister mentioned, the risk factors. So we have the cultural practice. We have application of unsterile herbal preparation, and then introduce bacteria, causes irritations, and then prevents normal healing because of the herbal or the concoction the client used. Now it has affected the wound and is causing all those problems. Please, the next one. And then we have the constipation. So with the constipation, with the risk factor for infection and breakdown, we have the constipation, increased perineal pressure. So when the incision site is sutured tightly, it can increase the perineal pressure and cause other problems, delay healing, and then promote wound separations. Please, can someone take over?
Hello, good evening. Please, I'm Dr. Aka. So the comprehensive wound care management plan, we have the immediate action. That is, we have to stop the use of herbal preparation immediately. Please, next slide. So cleaning technique. You wash hands thoroughly. You use normal saline or warm sterile water. You clean from front to back. Then you pat dry and with sterile gauze. You avoid rubbing. You perform cleaning. After urination, you perform cleaning after urination, then after defecation. Then you do this twice daily. And with a sit bath, you have to do a warm sit bath for 15 to 20 minutes, then 2 to 3 times daily. Then it promotes circulation and drainage. Please, next person.
Hello, please, good evening. I'm Comfort Mensah. I'll continue from here. So we are talking about positioning. Sideline position preferred. Avoid prolonged sitting. Use soft ring cushion if sitting. And then encourage rest with legs slightly apart. Please, next slide. So we are continuing. Pharmacological management based on severity. 1. Antibiotics as prescribed. Broad spectrum antibiotics. Example is amoxicillin, clavulinate or metronidazole, depending on culture. And then 2, you give analgesics, that's paracetamol, ibuprofen, if no contraindication. And then 3, stool softness, that's lactulose. What is it? Please, the last one, I can't see it well.
Docusate sodium.
Okay, docusate sodium. Thank you. And then we have possible surgical review. That's 1. If severe dehiscence may require resuturing after infection control. Please, someone can continue. Okay.
Please, please
let me
effect on pain. Straining increases perineal pressure. Pressure worsens wound separation. Pain causes stool retention. That is vicious cycle. Delayed healing and infection risk increases. Please, next slide.
Please let me continue. Please let me continue. Constipation, I'm Albinabochi. Constipation management plan. Intervention. A, dietary. High fiber diet. Fruits, that's pawpaw and oranges. Vegetables. Whole grains. Increase fluids, that's 2 to 3 liters daily. B, pharmacology. Stool softness. Mild laxative if necessary. C, education. That's passing stool does not tear stitches. Support perineum with clean pad while defecating. If someone should continue from here.
Okay, so should I go?
Oh, yeah, go.
Culturally sensitive education plan, important. Do not dismiss traditional beliefs harshly. Approach 1. Acknowledge respectfully. Example, I understand your mother-in-law want to help you heal quickly. 2. Explain scientifically. Some herbs may contain bacteria. The wound needs clean, sterile care to heal properly. Offer safe alternatives. 1. Warm seat bath. 2. Saline cleaning. Prescribe ointment. Involve family if possible. Educate mother-in-law gently. Emphasize safety for baby and mother.
Let me continue. Okay, empower the mother. 1. Teach signs of infection. 2. Encourage reporting worsening symptoms. Next slide, please. Follow-up plan. 1. Review in 48 to 72 hours. 2. Reassess reader score. 3. Check pain level, discharges, temperature, and bowel movement. Next slide. Refer to specialist if 1. Fever is above 38 degrees Celsius, increasing wound separation, necrotic tissue, signs of systemic infection, no improvement after 5 to 7 days of antibiotics, and lastly, suspected deep perineal abscess. Next slide, please. Also, you have to refer to obstetrician or gynecologist and surgical team if needed.
Please, can I take?
Yes, you can take over.
Can I take the summary?
Yeah.
Mrs. Fatima has 1. Severe infected episiotomy, wound dehiscence, constipation complicating healing, and then cultural practice affecting recovery. Please, next slide. Management required: immediate infection control, proper wound dressing, bowel management, culture sensitivity, close follow-up. Please, next slide. References.
We are done. Thank you.
We are done. Thank you.
Please, can the next group do it for next week?
Please, it's 6 p.m. Well, how many minutes are we supposed
15.
to use? If not, the Zoom will take us off.
15 minutes.
Jory, to share your screen, we can do it.
Somebody has shared, so let them.
Please start.
My name is Josephine Entry from Tamale Center, presenting on postpartum family planning and birth spacing. Our scenario: the unprepared couple, Mr. and Mrs. Kofi Asante, are in the postnatal ward. Day 1, after the delivery of their 4th child in 5 years, Mrs. Asante, 27 years old, appears exhausted and anemic with HP of 8.5. The couple had intended to have only 2 children.
Then once
but-
man a work come on. Hey, once must work.
Sister, please mute yourself.
The couple had intended to have only 2 children, but have experienced 3 unplanned pregnancies. They are confused about family planning as they have tried condoms inconsistently, and Mrs. Asante stopped her oral contraceptive pills during her 2nd pregnancy after hearing they were dangerous. They are both Christians and are unsure what methods their faith permits. Mrs. Asante is breastfeeding and wonders if this will protect her. Mr. Kofi asks about vasectomy, but is worried it will affect his manhood. So the goals of counseling are: we will provide accurate postpartum family planning information. We will also address myths and fears, promote healthy birth spacing for them, respect religious and cultural values, and also support informed shared decision making. Please, if someone will continue from here. Okay, so the postpartum contraceptive options. We have 1, lactational amenorrhea method. 2, condoms. 3, implants and injectables. That's the Depo original, the 3 months and the 1 month. Postpartum IUD, the Copati, progestin only pills. And we have the permanent method, either the vasectomy or the BTL, bilateral tuber ligation. Please, should I continue or someone will continue from there?
Network is coming. Did you come? Network is coming. Did you come?
Madam, hey.
Please, I'm Gloria. Thank you very much. Please let me take it up from here. Hey, who is that instrument? Please mute yourself. Lactational amenorrhea method. 1, effective only if all criteria are
Madam
met.
Naomi, what is that? Ah,
2, baby less than 6 months old. 3, exclusive breastfeeding, day and night. 4, no return of menstruation. 5, about 98% effective when used correctly. And then the last point is protection reduces when conditions change. Thank you. Or should I continue? Hormonal contraceptive and breastfeeding.
Let me continue, please.
All right.
Please, I'm Benedicta Akofo from Tamale. Hormonal contraception and breastfeeding. Modern hormonal methods are safe. Do not cause infertility. Progestin-only methods safe during breastfeeding. Do not harm breast milk or progestin-only methods safe during breastfeeding. Do not harm breast milk or baby growth. Combined pills started after 6 weeks postpartum. Please, the next slide. Permanent method counseling. Vasectomy is simple, safe, and effective. Does not affect masculinity or sexual performance. Semen appearance remains the same. Female sterilization is another permanent option. Best for couples who completed family size. Please, the next slide.
Yes, I'm continuing. I'm Gifty, February Gifty.
Okay.
Risk of short birth intervals. Worsening maternal anemia, maternal exhaustion and poor recovery, high risk of complications, premature birth and low birth weight. WHO recommended at least 24 months spacing. Respecting religious and cultural values.
Please, let me take it from here. I'm Rebecca Shedua. Respecting religious and cultural values. Family planning supports responsible parenthood. Protects health of mother and children. Encourages couple discussion and mutual consent. Offer both natural and medical options. Promotes informed choice without pressure. Recommended plan for couple.
Please let me take it.
Okay.
Okay, I'm Charity also. Recommended plan for the couple. 1, immediate, LAM plus, condom use. 2, long term, that is the implant or the IUD. And then you consider vasectomy if family is complete. Regular follow-up and counseling. Focus on maternal recovery and nutrition. Next slide. Take it away.
Please let me
Because
take it.
family planning saves lives. Healthy space and improves maternal recovery. Prevents pregnancies. Supports family moving. Own choice. That is also essential.
Angelina, mute yourself.
So thank you.
Hello.
Hello.
Please, that's the end of our.
Hi,
Thank
sister.
you.
Okay. All right. Thank you so much. Yeah, I think I've been following, and so far I think we've all done well. I think it's a few of you because the reason why I made it in a scenario form is for it to be more of discussion. Like we discuss the condition. Yes, so it's not like you coming to read
the topics were. But that's why I didn't make it in topics, but that is making or centering your PowerPoint around a scenario. And so, like I said, I think most of you did well. A few were like, okay, so the scenario is somewhere, and we are also doing our presentation without any connection to it. All right, so thank you so much. I think we've exceeded our time a bit, but thank you for your patience and everything. Miriam, I don't know, were we able to exhaust everybody?
No, 7 groups presented, so we have 3 more left.
Okay, all right, that's fine. I think that's fine, because I was even thinking we would not be able to even do. I was hoping for 6, but I think you've done well. So thank you so much, and thank you, Miriam, and the other reps as well. And so, God willing, next week, I think the 3 can do it. Then we continue with our main lecture for the day. All right. So have a good night, everyone.
Same to you.
Thank you, sister.
Thank you.
Enjoy your weekend.